Assalamu alaikum. My name is Dr. Sheikh, and today we'll talk about pancreas exocrine. The first thing I mentioned is exocrine. What does I mean by exocrine? Because we should remember that pancreas have two functions. That whenever we say the name pancreas, that the first thing what comes to our mind. I don't know about you, but the first thing which comes to my mind is pancreas have an endocrine function, and that is pancreas actually release insulin. Yeah, we all know that. We all know that the pancreas is releasing insulin, which help in balance of the blood sugar level into the blood. So what happened here is pancreas also have exocrine function, which help in digestion. So what happened here is pancreas release amylase and lipase, and trypsin, which all help in fat digestion, and we all know the lipase help in fat digestion, and amylase help in carbohydrate digestion. So what happened here is in pancreatic exocrine, the first disease, a congenital disease. What happened here is there is a head of the pancreas. Suppose this is the head of the pancreas. This is a head of the pancreas, this is a body of the pancreas, and this is the tail of the pancreas. And we all know there is a duodenum which is surrounded by the pancreas, just like second part of the duodenum. Okay, so what happened here is this head of the pancreas, it's bend over, and it's try to hug, just think like it's a hug the obstruction in the opposite direction. And what happened here, when it's hug or it's bended over the duodenum, then what happened here, the duodenal obstruction will occur. Okay, it's like a squeezing the duodenum. So what happened, duodenal obstruction will occur, and this is called annular pancreas. ANNULAR, annular pancreas. Okay, this is called annular pancreas, which is duodenal obstruction due to the bending of the pancreas. Now let's jump up to the next disease, and the next disease is acute pancreatitis. So acute pancreatitis. So in acute pancreatitis, okay, acute pancreatitis. Okay, what happened in acute pancreatitis? Okay, let's have a foundation first. Make a foundation of acute pancreatitis. Okay, so pancreatitis release different type of enzyme which help in digestion of the carbohydrate, fat, and protein, whatever. But this enzyme, why this enzyme doesn't digest pancreas itself? Why not? And how about stomach? Why? This is the very basic question you should ask. That why don't stomach doesn't get digestion by itself? Why pancreas doesn't get digestion? Because this enzyme actually digests the fat. That this enzyme and pancreas have a fat, and this enzyme digests protein. So, but and the stomach is made of protein, and there are muscles, smooth muscles, mucosa. Then why don't this stomach doesn't get digestion, when we all know that in the stomach there is a pH is less than 3, and it is highly acidic, HCl. So why don't stomach get digest itself, or pancreas get digest itself? Because stomach have a thick mucous layer which prevent autodigestion of the stomach. At the same way, pancreas have a, suppose this is a pancreas, this is a head of the pancreas, body of the pancreas, and tail of the pancreas, and this is the duct of the pancreas. This is called uh, uh, ampulla of Vater. This is called ampulla of Vater, and this is a inspector of Oddi. Okay, so what happened is enzyme release in the duct and passes through the duct, and through Oddi it releases to the duodenum when the food particle is passes through, and it's released to the duodenum. So until it release from the inspector of OD, it is in active form. The enzyme is in inactive form. When it release into the duodenum, that inactive enzyme will activate it itself, and in the presence of food, this enzyme will activate it and release due to the food particles in the duodenum. But until it release, this enzyme will be inactivated in the duct, and this duct have a very thick layer which actually protect the pancreas to digest itself. Okay, so that makes sense. That's why this enzyme doesn't activated during it's in the pancreas, but when it release from the pancreas and it goes to the duodenum in presence of food, it will activate it and it will digest the fat like a fat. So now the question is, what if this enzyme is activated in the pancreas? What gonna happen? The question is very valid because this enzyme can be activated. How? The risk factor. First risk factor, a very bad risk factor, and I'm sure you are all almost try to identify the most valid cause is what? Alcohol. Yes, alcohol. Alcohol is the worst, and second worst is gallstone. For Western world, alcohol is the major cause. For developing countries like Bangladesh, India, or Pakistan, gallstone is the major cause. So, what happened if we consume too much alcohol? When we consume too much alcohol, what happened here is this inspector of OD, which is relaxed during there is the food particles in the duodenum, which is relaxed and it will release the enzyme. But what happened when we consume too much alcohol, this inspector of not relaxed, it will constricted form. When it is constricted, then enzyme don't able to release into the duodenum, and there will be too much enzyme into the inspector of OD here, and this enzyme may activate in inactive form. Enzyme will activate it due to the constricted of the inspector of OD due to alcohol. So alcohol, what alcohol do? Alcohol constrict the inspector of OD, which partially or mostly activate the enzyme. And what gallstone do? Suppose this is a gallstone, and what gallstone do? Gallstone actually obstruct the ampulla of Vater. So when ampulla of Vater or the duct is being obstructed, then enzyme cannot move out. So what happened? Of course, again there is a premature activation of the enzyme. So this premature activation of the enzyme will digest the pancreas itself, and the pancreas will digest the enzyme will digest the pancreas in the central of the pancreas. Just look at here, this is they are digest the pancreas. And always remember, this is a central part of the pancreas, and there is a peripheral part which is full of fat deposition. These are the fat. So central of the pancreas is pancreas itself, and peripheral of the pancreas is a fat. Why I'm mentioning this? Because there is a very good diagnostic criteria, you will understand. Okay, now let's talk about it. When the enzyme will activate it, it will activate it and it will digest the pancreas. So there will be a liquefactive necrosis. So liquefactive necrosis. Liquefactive necrosis due to what? Due to digestion of the pancreas itself. And there will be also fat necrosis. Why fat necrosis? When the digestion of pancreas will occur, and it will digest from the central to the peripheral. In that moment, the fat necrosis will occur. So by seeing the fat necrosis, you will understand that digestion, autodigestion occur too much, or the prognosis is very bad. The severity of the case is bad, because it's not only digests the central of the pancreas, it's also digests the peripheral and peripheral of the pancreas, because in the peripheral of the pancreas have fat, and fat is also necrosis occur. Now the risk factor, there is one more risk factor, that is hypercalcemia. Remember, excessive calcium level will actually badly influence all the internal body part, and it also badly influence the pancreas. So it make hypercalcemia may cause the acute pancreatitis. But when the acute hypercalcemia occur, the acute pancreatitis, but in severe cases there will be decreased calcium level. Why there is a decreased calcium level in severe acute pancreatitis? Because as I told you, that fat necrosis actually consume the calcium. Fat necrosis consume all the calcium, necrotizing fat necrosis, which consume all the fat necrosis, all the calcium, serum calcium into itself. So there will be less calcium into the serum. So remember the fact that although the calcium level, increased calcium level, actually activate the autodigestion of the pancreas, which cause acute pancreatitis, but when the severity is increased, the calcium level will decrease. And when you see the serum calcium is decreased, you should understand that, well, now the pancreas digest itself. It's not only digest its body, it's also digest its extremities or peripheral fat necrosis. So by hypocalcemia, you can understand the prognosis is very bad. It's in bad or severe condition. Okay, another risk factor is hyperlipidemia. That makes sense. And mumps virus can also cause pancreatitis. Mumps virus can also cause other two things. Can you remember? Yeah, it can cause orchitis, means how to say, impotency in adulthood if you didn't treat with prednisolone. And there is one more cause, complication. It's meningitis in mumps virus, and another is of course pancreatitis itself. So three mumps virus can cause three things: meningitis, pancreatitis, orchitis. Okay, now let's talk about this topic. So MUMPS, mumps, lipid, increased lipid, and of course drugs. So what type of drugs may cause the acute pancreatitis? Thiazide diuretics. Of course, we all know thiazide diuretics. Thiazide diuretics may cause the acute pancreatitis. And there is one more drugs. There are other drugs, but remember these two at least. Azathioprine. What is azathioprine? Azathioprine is a drug which will prevent in autoimmune disease like rheumatoid arthritis. We can give azathioprine in autoimmune disease, or like rheumatoid arthritis, or we can use azathioprine. Not enough space. Okay, azathioprine. So we can give azathioprine when body reject the new organ. as a foreign body. Suppose we have a kidney transplant to a patient, and the patient's body think this new kidney as a foreign body. So what happened here? When it's take the new kidney as a foreign body, it will try to destroy the kidney as a foreign body, a foreign material, or think the kidney as a parasite and try to destroy it. So in that moment we give azathioprine. So one hand, azathioprine will help to help in uh, prevent the rejection of the organ, but on the other hand it may cause acute pancreatitis, so it's have a bad effect too. So these are the few facts you have to know, the risk factors: so alcohol, gallstone, hypercalcemia, hyperlipidemia, mumps, and drugs, thiazide diuresis, and azathioprine. And now let's talk about clinical feature. So what are the clinical feature? Let's go to next page. Okay, I like this background. Okay, now the clinical feature. So clinical feature, first clinical feature, you have to know the anatomy of the pancreas, where the pancreas is placed. Of course, pancreas is placed in the upper quadrant, so so epigastric area. So epigastric pain, there will be epigastric pain. Epigastric pain, okay, which radiate to the back. So this is the first clinical feature you have to remember, that epigastric pain which radiate to its back. Then very normal nausea and vomiting. Yeah, so nausea and vomiting. Okay, this is the second clinical feature. And the third clinical feature of we have to see, we already talked about the clinical feature is decreased calcium level. Yeah, remember the acute pancreatitis, the risk factor is increased calcium level, hypercalcemia. But when acute pancreatitis occur, and when the severity of acute pancreatitis too much that it not only digests the pancreas itself, but it also digests the from the central to the peripheral, where there is a pancreatic fat, and that pancreatic fat will digest. Then this fat necrosis will occur, and fat necrosis will consume the calcium, serum calcium, and the serum calcium level will decrease. And this I told you that this decreased serum calcium level will indicate that the severity of the pancreas, that pancreas not only digests the central of the pancreas itself, but it also digests the pancreatic area or fat area of the peripheral. Means it's almost affect the whole pancreas and above the pancreatic fat. And two type of necrosis will occur. One is liquefactive necrosis, when the necrosis occur in the pancreas itself, and when the pancreas occur in the peripheral, in the peripancreatic fat tissues, then there will be fat necrosis will occur. So decrease of calcium level. Now the next thing we have to remember, there will be elevation of the elevated serum amylase and lipase. Lipase is more specific because amylase can also be increased in salivary gland disease. So lipase is more specific, and amylase and lipase is released by pancreas. Lipase is help in digestion of what? Amylase is help in digestion in what? Amylase is help in digestion in carbohydrate and converted it into the glucose. Lipase is digest in fat into fatty acid. Okay, that makes sense. Should I have to write it down? Okay, you can write it down like not protein, sorry. Okay, fat into fatty acid by lipase, and carbohydrate into glucose by amylase. Okay, so elevated serum amylase and lipase. And lipase is more specific in diagnosis criteria. There will be decreased calcium, nausea, vomiting, epigastric pain, which is radiated to its back. And there is one more sign that is called Colen sign and Gray Turner sign. So remember Colen sign. Colen sign and Gray okay, Gray Turner sign. What happened here in Colen sign is frank hemorrhage in the periumbilical. Frank hemorrhage, there will be hemorrhage surround the umbilicus. I will show you one picture. And Gray Turner sign, there will be retroperitoneum hemorrhage. So in retroperitoneal area there will be a hemorrhage or bleeding in the peritoneum during acute pancreatitis. So let me show you two picture that will what is colon disease. This is colon disease. You can clearly see there is a hemorrhage in the periumbilical or surrounded the umbilical. There is a what hemorrhage or frank hemorrhage. And one more, you can see it's a Gray Turner sign suggested that it's a retroperitoneal hemorrhage or bleeding in the peritoneum. You can clearly see here. So these two are Gray Turner sign. This is Gray Turner sign and this is Colen sign where there is a hemorrhage in the periumbilical. Now let's jump up. Okay, so we now know the clinical feature. So let's talk about complication. Okay, complication. What are the complication? There are many complications. The first complication you have to remember is shock. Why shock occur? There are the main cause of shock is, as I told you, that when pancreatic enzyme, this is pancreas, this is a ampulla of Vater. When pancreas activated its enzyme, what happened? It will digest from centrally to the peripheral, right? And it digest from central, then it digests the peripheral, and it also digests different blood vessels surrounded by the pancreas. Yes. So when it attacks the blood vessels also, what happened? Yeah, shock may occur. So due to peripancreatic hemorrhage and the fluid sequestrations will occur. What happened here is digest the blood vessels surrounded by the pancreas, and that will cause shock. That makes sense. The next is I remember three things together. I hope you can remember two. Cyst, mass, abscess. This three name makes sense together to me. So there will be a pancreatic pseudocyst due to the in the pancreas there will be fibrous tissue will form, so that may cause a pseudocyst. It's not a real cyst, means there will be no fluid accumulation. It looks like a cyst, but it is not accumulated by fluid. On the other hand, it will be just a fibrous tissue. Pseudocyst, that's why it's called pseudo, means false. It's not true. And we know the criteria of the cyst. Yes, there will be some sort of fluid or serous fluid, and there will be mass, and there will be abscess. So what happened here is, in abdominal mass, there will be present with increased amylase, and maybe abscess will occur due to the bacterial infection E. coli. And these three pseudocyst or mass or abscess, what will be the result? Rupture. Rupture is the result. So just remember like this way. First, shock due to the digestion of the blood vessels surrounded by the pancreas. Then there will be pseudocyst due to the fibrous tissue that will cause a false cyst-like appearances, and there will be a mass, abdominal mass, and there will be a abscess due to the bacterial infection like E. coli, present with abdominal pain, high fever, elevated amylase, and all cyst, mass, and abscess will cause rupture. That makes sense now. And this rupture will cause what? This rupture will cause, from the abscess there will be many enzyme will release to the blood vessels. If there is a mass, all the enzyme will release. There is a pseudocyst, all the enzyme will release to the blood vessels. So what happened? When the rupture occur, there all the enzyme will be in the blood vessels, and what it will do? When it does, enzyme will mixed in the blood vessels, it will do DIC, disseminated intravascular coagulopathy. So coagulopathy will occur due to the enzyme mixed in the blood. And when this blood is go to the alveolar area, in the alveolar capillary, then it will cause acute respiratory distress syndrome. Yeah, too many complications. So complication, just remember like this way: shock, then these three things together, cyst, mass, abscess, then anything may rupture, somehow it's get ruptured, and this enzyme go to the blood vessels and causes disseminated intravascular coagulopathy and acute respiratory distress syndrome. So these are the complication. So I hope you understand the basic concept. So let's summarize the whole thing together. First, we talk about the annular pancreas, how annular pancreas is obstructing the duodenum by bending and hugging the duodenum, and it's obstruct the duodenum. Okay, the head of the pancreas actually bending and hugging the duodenum and obstructing it. Now we talk about briefly acute pancreatitis. So what happened in acute pancreatitis? Pancreatitis, this means inflammation. Of course there will be inflammation. Anywhere you find TIS, uveitis, or any TIS, you find there is some sort of inflammation. So acute pancreatitis, there is an inflammation and hemorrhage of the pancreas. How it happened? It happened due to the autodigestion of the pancreas itself, due to the premature activation of the pancreatic enzyme which help in digestion. And this enzyme actually released in the inactive form in the pancreas, but it activated when it released to the duodenum. When this inactivated enzyme is activated into the pancreas itself, then the autodigestion occur. When this inactive form of enzyme is activated in the pancreas due to the alcohol, which actually constrict the inspector of Oddi, or due to the gallstone, which obstruct the ampulla of Vater, or due to the mumps virus, or due to the drugs like azithromycin or thiazide diuretics, or due to hypercalcemia or hyperlipidemia. These are the cause. And remember one more thing, that in pancreas we have two type of necrosis occur. In the central of the pancreas there is pancreas itself, that when it necrotizing, that's called liquefactive necrosis. And in the peripheral of the pancreas, there is a fat necrosis will occur. This is peripancreatic fat that will necrotizing and cause fat necrosis. When fat necrosis occur, it will consume all the serum calcium to itself, and that will cause hypocalcemia. And that are the clinical feature. There will be hypocalcemia, there will be elevation of the lipase and amylase. We all know that amylase may also increase in salivary problem. So lipase is a more specific for the diagnosis of the pancreatitis. And there will be a nausea, vomiting, epigastric pain, because pancreas in the upper quadrant area, and there will be a and which is radiate to the back. And there will be a two type of sign I will talk about: Collen sign and Gray Turner sign. Collen sign will be the frank hemorrhage in the periumbilical area, and there is a Gray Turner sign, which is a hemorrhage in the retroperitoneum. So these are the clinical feature. And last but not the least, we talk about complication: shock due to the blood vessels dissection in the surrounded pancreatic area, then cyst, mass, abscess, pseudocyst, which is due to the fibrous tissue which looks like a cyst, but it's not a cyst, it's a false cyst, and may due to E. coli bacteria, abscess may occur. And rupture is the complication, and rupture will do two things. It will release all the stuff, all the enzyme into the blood vessels, and that will do two things: disseminated intravascular coagulopathy of the blood, and when the blood goes to the alveolar capillary, it will cause acute respiratory distress syndrome. And that's the whole picture of the acute pancreatitis. And next lecture we will talk about chronic pancreatitis and pancreatic carcinoma. Thank you very much.